So we're just going to jump right into it. A real world patient with a fictitious name. And I'll give you a little background on him. The first, the vignette. This gentleman is a 39-year-old IT systems analyst with no past psychiatric history, referred for mental health assessment by his PCP during the COVID-19 pandemic due to complaints of anxiety, poor focus, trouble staying on task, and increased difficulty in keeping up with his workload. We saw many, many patients like this early on, midway through the pandemic. His PCP was contemplating initiating antidepressant treatment, concerned that the stress of the pandemic was causing emotional symptoms that were beginning to impact his ability to work, but wanted a comprehensive mental health assessment prior to initiating any therapy. Carlos reported to be in his usual state of health until shortly after the pandemic started. He described, so this right here, usual state of health, is a little bit of a red herring and can be a subterfuge in some of these cases. So I want to draw your attention to that. Until shortly after the pandemic started, so it makes you think this is pandemic related. He describes stressors and concerns which were experienced by many during that time, primarily centered around maintaining a safe environment for himself, his family, and his elderly parents. He was also concerned regarding the impact the pandemic would have on his job and family's financial status. Very common and normative concerns at that time. Carlos oversees IT operations for a large healthcare operations, and as it turned out, business was his workload was steady and there was no financial hardship. Early into the pandemic, Carlos transitioned to working remotely from home, which made him feel more at ease regarding exposure to COVID-19. At no point did he, his wife, or his two children contract COVID-19. Certainly not before we saw him. Medical history indicates borderline hypercholesterolemia controlled with diet. He's on no medication for that, supplements, and exercise. Past psychiatric history was negative for any anxiety, depression, mania, hypomania, mania, no treatment episodes with psychotropics or psychotherapy. Current meds were over-the-counter vitamins and fish oil. Substance history, negative for any offending agents, no tobacco, excess alcohol, recreational drug use. Family medical and psychiatric history indicated cerebral vascular disease from his father and ADHD in son. He denied any incidents of familial mood or anxiety disorders. Psychosocial history revealed that Carlos had been born and raised in the U.S. to parents who had emigrated here from Latin America. He obtained a master's degree in information systems and had been with the same health organization for 12 years. He had been married for 10 years and lived with his wife and two children, 8 and 6. So that's one of the classic cases that we saw. So my practice is housed in a large neurology practice. So it's not unusual. PCPs are going to refer anyone with cognitive, affective, emotional, behavioral issues, our way in order to kind of screen them from anything, from any type of neurologic illness first before going to primary psychiatric settings. So the lecture is lessons learned from the pandemic. I don't want folks to think that we discovered the link, link between SARS-CoV-2 and ADHD. No. The lesson that we learned was we saw several of these cases, and over time they started to amass, and there was a recurrent theme that came through in all of these cases, and that lesson, those things that we learned made it very salient and apparent to us that years of working with ADHD, we can kind of distill the symptomatic presentation to the situation that happened with Carlos. So we're going to talk about transitions. Our observations with our series of patients that we saw in the office led us to take a broader view and we reviewed the current, the DSM-5 category criteria for ADHD. And I don't know if folks in the audience have a copy of that article. I had Continuing Education send that out. If not, let me know. My email address is on the slide, so if you all have any questions afterwards, or if you want a copy of that article, I'm happy to let you know, because this whole lecture, everything that stimulant treatment. You want to get these folks on treatment. It is a dramatically robust response to stimulant therapy. I'll make a couple of comments about that later on. So we're not going to dive too deep into this. The article that we published has a lit review on these studies. Essentially, part of that discussion that you have, with parents or with your adult patients is, think about ADHD as frontal lobe immaturity. It's just not working as well and as efficient as it should be at doing the things that the frontal lobes should do. And this is the prevailing and traditional view of that frontostriatal cerebellar pathway in terms of behavioral regulation is not functioning optimally. So there is data from imaging studies, neuroanatomical studies, showing that there are some morphometric changes that are present, but not everyone has these changes. It's not diagnostic in nature, but when you look at enough patients, you'll find these changes present in a percentage of the patients. There's data that some of those alterations or brain variability can persist into adulthood, probably serving as the mediating with the persistence of symptoms are. And kids that outgrow it are probably ones that just have a little bit of a developmental lag and then kind of catch up. Remember that brain is going to continue maturing into mid-20s, and the part of the brain that comes kind of online at the very end of that and gets fully innervated, myelinated, and functioning well are the frontal lobes. So that pathway, to make a quick comment on the neurochemical functionality, that pathway is heavily dependent on two biogenic amines, norepinephrine and dopamine. You need the right balance of dopamine and norepinephrine in that pathway to have optimal frontal lobe functioning. So if it's too low, you're going to have dysregulation. If it's too high, you could also have dysregulation. You can kind of overwhelm the frontal lobe. So if anyone has done too much coffee and is really over-caffeinated and just kind of feel like they're wigging out and they're all over the place, they're hyper-alert to things, that you have kind of dysregulated that pathway. So what you really want to do you really want to just, with those medications, and again, the stimulants, all stimulant therapies, and by the way, stimulants are not the only medications for ADHD. We've got non-stimulant medications, probably 3 different classes of medication that are used as second line, but the stimulants have such a dramatic increase in efficacy over those other classes. And all the stimulants that are out there are just based on 2 molecular platforms, amphetamine and methylphenidate. And everything that's out there in terms of Concerta, Vyvanse, Adderall, Focalin, pick your stimulant of choice, is based upon one of those 2, with the one difference is how can we prolong coverage over the whole day. So methylphenidate is Ritalin and all of those medications. Vyvanse is one of the amphetamine preps. And those medications, what they do essentially is increase norepinephrine and dopamine tone in that pathway. I know some parents don't like medicating their kids. If the kid is falling behind in school, I strongly recommend doing it. A really interesting article, Geed and Rappaport, 2010, I believe in the journal Neuron, tracked some of these kids, and there's some data to show that kids with stimulant therapy seem to have brain growth and attain kind of normal markers than kids that are untreated. So we don't know. So two things may be going on. Either are these medications neurotropic and stimulating that brain development, or, which I probably I'm more in this camp, by optimizing functioning and optimal interaction with the environment, you're causing brain development in a certain pathway. Either or, it's interesting data and probably gives you greater evidence, to in your discussion with parents on having these kids on medication. So from the neurobiology and the functional issues, neuropsychologically, just think about executive dysfunction. If the neurobiology is frontal lobe immaturity, think about, and what do the frontal lobes do? Executive functions, right? So anything that in our older patients that have some type of CNS insult or trauma, a head injury, a stroke, and are having multiple sclerosis, and are having executive dysfunction secondary to that, that is what these folks have difficulty with across all of these different cognitive and self-regulatory processes. So not only regulating alertness and focus, but these two, the capacity to maintain attention and to shift tasks. And this is a critical one, and this textbook definition that doesn't really capture what we know about ADHD, right? So they dropped that term impairment. They're critical issue there. And then expanding on that, clear evidence of impairment, they changed to clear evidence of interfering with or reducing the quality of psychosocial function. So, and this reflects how some people compensate and use external supports to offset the development. I really wish they would have used a term that I hear all the time from my ADHD adults, and that is inefficiency. I'm just inefficient. It takes too long. Yes, can that be captured under interference? Yeah, but I think a more euphonious term for our patients is describing themselves. I'm just really efficient. That's why everyone knows that I get caught up in my efficiency goes low. So I wish that they would have included language like that. Think about that as their theory. They also changed the verbiage here from type to disability because there is something that the disorder can change over time. These are really important. So what they codified was, the severity specifier. We are most familiar with various specifiers in DSM for major depression. But you can apply severity specifiers for many of the disorders. And the way that they work, as most of you I'm sure know, is that you take the full symptom range. So let's say for major depression is 9. You take the threshold, the symptom threshold that you need to make the disorder, that's 5. And you start when someone comes into the office, 5, 6 of 9, you're thinking mild. 8, 9 of 9, you're thinking severe, and then you factor in distress and dysfunctionality. And then you go back and forth on that continuum. So it's and you can do it for any of the disorders. Panic disorder, full symptom threshold, full symptom profile is 13. You need 4 to make the diagnosis. If you have someone with 4 or 5 and they're functioning relatively well, they got mild panic. Someone's got 12, 13, all of the panic symptoms, and they're shut in at home. That's severe panic. So the nice thing here is that they codified that into the language to highlight our awareness that there are ranges in ADHD. And the ones that we are worried about, the folks that we're worried about missing are these folks, the mild folks. The ones that walk into our office that have, the 40-year-old that's done relatively well and kind of has limped along with these symptoms and then something's happened. That individual probably doesn't have moderate to severe, right? Because they got busted at some point. Those folks probably had borderline, mild illness and were able to get by. So that's a very significant change, and now we can conceptualize this as varying severity. And then this is a real important issue because the remission specifier, where it can go into partial remission, because certainly we know that there are times when if the environment does not require your frontal lobes to function a certain way, you're going to drop below that clinically significant threshold. So thinking about ADHD as being able to go into partial remission is really, really helpful for us. And I think highlights this notion of environmental interaction, which was one of the things that I think that those cases that we saw during the pandemic underscored for us, and maybe shown a light on the fact that there's a really interesting kind of cool environmental interaction. We don't think about mental illness as having an environmental interaction, right? Not the way that you have to be exposed to something, you have to be exposed to COVID, to HIV, a head injury, some interaction with the environment, and then the pathology ensues. With the exception, of PTSD, which obviously is an acquired illness. The sine qua non of PTSD is the T, a traumatic event in the environment. But we don't think of most of our illnesses, in this way. Certainly, the mood disorders become a stressor could set them off, but in chronic, in bipolar disorder and chronic recurrent major depression, you can have these independent, autonomous episodes that are that don't rely on the environment to set up or precipitate an episode. But the interaction with ADHD is, again, if that individual is in an environment where they've developed really good strategies, or the environment is not demanding, they're going to drop below clinical significance threshold, and they're going to go undetected, right? So we really have to be aware of that, and that's what we saw during the pandemic. These individuals were interacting with the environment. Something changed for them, and it kind of highlighted this point. So, making the ADHD diagnosis. So this can be a little bit of a provocative. So there's no genetic, biologic, or psychometric test for ADHD. And as psychologists, it's probably, it may be good to debate this, but because I hear the layperson saying, yeah, my doctor said I got to get tested for ADHD. There's no test for ADHD. Sorry, there's no psychometric test. This is, I will pause it if someone wants to write in a question. I will answer it now rather than get to the end to make it more immediate. But I want to be really, really clear that the diagnosis is a clinical diagnosis. It's made on the basis of primarily history, even on mental status. If you've got someone with mild illness, they could sit throughout the consultation without any unusual or positive characteristics. You're going to exclude medical causes. So certainly a head injury, MS, seizures, COVID, right? And the first thing that we did with these folks when they came in, your doctor referred you for pandemic-related stress, and you're having these cognitive and emotional issues. Have you had COVID? And they did. The ones that we reported on didn't. So someone who, the 30-year-old, the 40-year-old, that gives you an ADHD profile that's lasted a year, and you did a obsessively meticulous job. You turned over every stone in their, prior to the age of 12, through schooling, through college, and there's not a whiff of ADHD, that's not ADHD. Adult ADHD is not ADHD that emerged, that they caught during adulthood. It really should be ADHD that they've always had throughout their life, but it's never been detected until adulthood. But that's really lengthy, so people say adult ADHD. But we just need to be really clear that when we get these cases, there is a role for psychometrics, but it's not to necessarily confirm the diagnosis. do more detailed questioning like you should, and realize that it took them a lot longer to do things because they were inefficient, but they benefited from compensatory strategies and scaffolding. So a really interesting concept of when you look at when you look at the kids that are doing well in school but have the ADHD, how the environment has responded to put this overlay, this structure around them, and do one-on-one tutoring after school, have a parent sit with them doing homework, talk to the teacher moves them up. I've heard stories where the teenager male with ADHD, one of his friends, when they go out in settings, has to kind of ride herd over him and make sure that they behave a certain way, that they don't get into fights, that they don't get impulsive, that they don't say something inappropriate, right? The scaffolding that takes place, and essentially, you can think of scaffolding as this auxiliary frontal lobe that's performing executive functions for the individual, hopefully, and they'll outgrow it. The other thing that you'll find with these folks is that they have developed compensatory strategies. And it could be as subtle as knowing when to take breaks, where to, structuring their work area, interacting with certain people, things that help them study a certain way. Now, we all benefit from those things, to be clear, but for these folks, the moment you take them away, they kind of fall apart. So that's a telltale sign, right? So you're looking for elements of scaffolding in the past that allowed them not to function well, and then elements of compensatory strategies. So, and while those two components are very, adaptive and can facilitate functioning, the problem is that they can mask detection when they were younger, and folks may not be able to get, weren't treated because they were doing relatively well with this support. So, what gets in the way of detecting adult ADHD? First, clinician error. We either just don't know the criteria well, we're misapplying the criteria. On the patient side, sometimes their capacity to recall is difficult. Remember that you'll have your ADHD folks tell you I have memory problems. It's not real memory problems. It's attentional and organizational problems, because that's obviously the first step of memory and coding. But these folks have kind of patchy memory lots of times of their childhood and can't tell you clear. So if you have access to a collateral informant, and that form that checklist does have different heading for collateral, so you could have someone else fill it out. Cultural factors. Again, we're in Latin America. I mean, we're in Latin America. We're in South Florida, which is like Latin America in a lot of ways. But and a lot of folks adults that grew up in other countries, there's a cultural component here, and they some of them laugh, and I hear it all the time. No, we didn't have that. We didn't have that in my country. When you ask them about ADHD, yeah, my son's diagnosed with it now. I was the same way, but back then they would just slap you and send you to class. We didn't have the disorder, right? Talk about it, viewing behavior from a cultural lens, or there was much more, mental health stigma associated, which prevented them from getting treatment. So some of those cultural elements can certainly, factor in to the way the behavior is being recalled, portrayed, or treated in their countries. Look for scaffolding and compensatory strategies. Look to see how much, if they did well when they were younger in school, were there elements of scaffolding? How much, were there tutors? Were the parents very involved? These types of things. Lots of times, obviously, the symptoms can mimic primary psychiatric issues, such as depression, anxiety, are the two big ones. Our series of patients, they were being attributed to stress, pandemic-related stress. So it might be misattributed to anxiety, depression, or a lot of times these folks have comorbid anxiety and depression, which makes it not only a little difficult to detect, but also how are you going to treat it? My experience is there are some folks that just flat out need treatment for depression and for depression/anxiety. Thankfully, one medication is going to treat that, and stimulants. There's some folks that their depression and anxiety are because they're inefficient, not doing well, and once you treat this with a stimulant, this lowers, or you can throw psychotherapy at this and don't have to worry. But you don't want to start 2 different medications at once if you don't have to. If the patient gets better, you don't know which.
But they're not treating them; they're just doing coding.
So, again,
how do you make the code?
You see it, and it's just one of those.
How do you give them this? No.
Work your way through to get.
You decide they're not for therapy; they're for coding. They work with neurology, so they come in. You come into Baptist Health, and you have to buy the DSM-5. You have to meet the criteria, and they come with it. So that's what he's talking about. They changed from DSM-5 to DSM-4 the criteria. I asked them questions, but they don't respond. I asked that a lot of times AI could really work with this. They have the same questionnaires, you know. As the child, let's say, goes through junior high, high school, I'm recording.
to compensate for these shortcomings.
Alright.
And guess what happened during the pandemic? He transitioned to working remotely from home. And I'm telling you, it was so difficult for these folks. The cognitive change, when we leave the house to go to work, we are in our work, we don't even know it, but we get into our work mode, right? Our work is set up in a certain way. We interact with folks in a certain way. Having these individuals at home, when they're in their home mode, not able to make the switch, and there's the TV, the washing machine, the refrigerator, it was really, really tough for these folks to stay on task, not fall. You can't take a nap at the office, not very well anyway, unless you're George Costanza and you sleep under your desk. But it's tough. But at home, it's very comfortable. If you're a little tired, just go and lie down. Plus, a lot of these folks were dealing with the kids in the house, and that distraction was very, very difficult. So we did a full assessment. His psychometrics, by the way, bright guy. It was a negative study. We diagnosed him with ADHD, predominantly inattentive now. Probably combined, he met criteria for combined type as a child, but now inattentive type, mild to moderate range. He was placed on medication and was doing well at follow-up. So, in summary, here are the take-home points. Certainly it can persist into adulthood, but it doesn't start in adulthood. It may declare itself in adulthood, but you have to have signs that it was present before the age of 12. That's a really critical point to make. The numbers are such. Should we screen everyone for ADHD? We should be screening everyone for depression and anxiety. Should we screen everyone for ADHD? As they get older, the hyperactive symptoms tend to go away. The inattentive features tend to remain. Remember that. Think about ADHD as existing along a continuum, and a lot of your folks that you see have never been diagnosed and never had frank impairment are going to be folks that had kind of borderline, mild illness, right? Because the moderate, by definition, those moderate, severe folks are going to get caught. Look beyond, obviously, frank impairment. Look for areas of inefficiency. And again, the transitions are good opportunities, but don't get caught up in the transition being, or the symptom emergence is an emotional reaction to the transition. When you see that something happening after the transition, think, is it just increased environmental demands and decreased structure? That's all I got. How's that for an abrupt ending?
Dr. Rivas Vasquez, thank you very much. If there are one or two questions with quick answers, you're welcome to take them.
How do I take them?
At the Q&A.
Gotcha. Q&A?
Click that on.
Is there a relationship between ADHD and Alzheimer's? I recently saw some data on that. My knee-jerk is to say no. I would have to look at that paper to see how they're making the relationship. But I can't identify any neurobiological risk factor that would put an ADHD individual at risk for Alzheimer's. There's hesitancy for Sigmund-Stone patients. I know, but let's educate them that if you look at the long-term course of ADHD, folks who do the best are the ones that get treated primarily with the Sigmunds because of the response, than folks who don't and they kind of limp along. What you'll see from your patients that you follow after they start treatment is if they have that kind of classic robust response, is this bittersweet moment of, they're an adult and they say, I got started and wow, what a difference this makes. I'm more efficient, I'm doing better at work. That's the sweet part. The bitter part is a lot of these folks say, I wish I would have done this sooner. But, I would have finished college, I would have done this. So it's bittersweet. But let's talk to our patients about that because because it's a robust response. It's amazing. Has there been any changes in the diagnostic criteria in DSM-4? No, in DSM-5-TR there have not been. The text revisions, when you see the TR, it means that they augmented the text section. So data on twin studies, prevalence rates, they should not be, if they're true to the DSM form, of making significant changes to criteria in the text revisions. When they change numbers, that's usually where they do the criteria changes. Maybe one more. Do ADHD progressive bipolar disorder? No. There has been some controversy on overlap between ADHD and bipolar. I think it's indistinguishable. That's a tough differential diagnosis when you see some of these kids in crisis stabilization units. But ADHD by itself, uncomplicated ADHD, does not naturally progress to bipolar disease. There are references in the back of the handout.
It's more than
If there's
5
a
minutes.
handout or in my article.
He's answering my questions.
What other medications are used besides stimulants?
He's answered a couple of my questions.
Non-stimulant medication, which is
Okay.
a norepinephrine reuptake inhibitor, atomoxetine, Strattera.
His idea, drug him.
There's
That's
cardiac
it.
medications, which are alpha agonists.
Yeah, that's it.
They kind of slow down adrenergic outflow. And then Wellbutrin is a
I'm
really
asking,
popular
but I want-
medication.
That's all they're doing is medicate you, and that's it.
A mixed dopamine norepinephrine reuptake inhibitor used as an antidepressant. Dr. Crown, how am I doing?
You're doing fine. I want to thank you, Dr. Rivas Vasquez, for a timely
I want about, I asked about AI.
Oh, there's one more.
Yeah.
It's overwhelming for now. It's something that's very, very I want to thank you for your presentation. I want to thank everyone for attending.
Oh, where's the
Please
personal?
complete your evaluation
Supposed to end at 7.
form.
7:05, they started late, and I came, they just started, you know, and I came. Here's an
Thanks for joining us, and thank you again, Dr. Rivas Vasquez.
I never already responsive.
Thank you so much.
So basically what they said, I have it, all the nothing, just the only way to do it, medicate, give you stimulants, and you'll feel so much better. And it doesn't matter. I'm just telling you. And the way you diagnose is there's no way to diagnose. You answer these silly questionnaires, many times often. Anyways, you self-diagnose yourself.